Okay, we're going to get started here. I wanted to welcome everybody to tonight's virtual meetup, breaking down seizures, breaking down types of seizures. We've got tonight, very lucky to have Dr. Chad Carlson from Medical College of Wisconsin with us tonight. We're just going to go over a couple of housekeeping items. Please know that you are muted and your videos are off at this time. If you have questions for Dr. Carlson or any one of us, please type them in the Q&A section or in the chat section. Either one will do. Understand that depending on how many questions there are, we might not be able to get to all the questions. If that is the case, please feel free to email them to us. My colleague Alicia here is going to be has put the email and website into the chat section. So if you'd like to know our general email, you can open up the chat section and see them there. Alicia, why don't you say hello tonight?
Hi, everybody. John, you can hear me okay?
I can, yes.
Hi, everybody. So yeah, my name is Alicia Thompson. I'm usually the face that you see on these VMUs, but John also helps out. So very excited to kind of let him take the lead on this one tonight. But for those that don't know, I'm the program manager for the foundation and have been with the foundation for almost, wow, a year and a half now. It's just kind of crazy to think about. I'm excited to be here and to learn from Dr. Carlson. So John, I'll give it back to you.
Okay. And again, my name is John Mirasola. I work with Alicia for the Epilepsy Foundation of Wisconsin, and I'm generally in charge of client support as well as communications and social media and a support group as well. Let's see here. As again, our email and website, you should be able to open that up on chat. And you can ask those questions during the presentation. We just won't get to them until the end. But at the end, there will be some time to either through Q&A or chat, ask Dr. Carlson a question. Feel free to do that at any time. Okay, Dr. Carlson, it's all yours.
All right. Thank you very much for giving me the opportunity to speak tonight. I am going to take over the screen here. So hopefully you guys are seeing my screen now with these slides up. So as I mentioned, I'm Chad Carlson. I'm one of the epileptologists over here at Froedtert in the Medical College of Wisconsin in Milwaukee. I was asked to talk tonight about a breakdown of seizure types. I like to start out whenever I'm talking about seizure types with a little bit of additional terminology. I recognize for probably everyone in this audience that the term epilepsy is not a foreign term, but I always like to make sure that we're all using the same words in the same way. When we talk about epilepsy, a very formal definition of epilepsy is an enduring predisposition to having seizures. What that really translates to at a clinical level is having 2 or more unprovoked seizures. And that's been classically the definition of epilepsy for quite some time. In the more modern era, over the last couple of years, we have actually expanded that definition to include history of at least 1 seizure, and then something that makes the risk of recurrence of a seizure to be estimated to be over 60%. And so that's what we're talking about. When we talk about a seizure itself, what is a seizure? A seizure is a short circuit or an overactive area of the brain. And seizures can start in any number of ways. They can start in a small area. So it could be sublobar. It could be just a little spot here in the frontal lobe. It could be a large area. It could be the whole hemisphere, the whole side of the brain. It could be the whole brain all at once. Or it could be multiple different areas that may not be as closely linked together, that activate all at the same time, or they may activate at different times, causing different types of seizures. It's important to recognize that not everything that people use the term seizure for is actually an epileptic seizure. And increasingly, physicians have been trying to use other terms to describe things that look like or behave like seizures, but aren't actually epilepsy. Those sort of things we think of as seizure mimics, like passing out or syncope, anxiety and panic attacks, psychogenic non-epileptic events, which used to be called pseudo seizures. Less commonly, things like migraine or even transient ischemic attacks or strokes can kind of mimic a seizure, but aren't a seizure. They aren't that short circuit or overactive area of the brain. The other term that I wanted to address before we launch into specific types of seizures was, I mentioned that when we define epilepsy, it's 2 or more unprovoked seizures, which raises the question of, well, what's a provoked seizure then? Some people will also use the term symptomatic seizure, and either term, a provoked or a symptomatic seizure, is a seizure that occurs when there's some other challenge, some other insult that's directly to the brain or to the body on the whole. So a stroke, trauma, infection, brain bleeds, drug use or intoxication, metabolic issues, so changes to our electrolytes like very high glucose, very low glucose blood sugar, very low sodium as examples. Now, these things all have to happen very closely associated with the seizure. So if you had a stroke 20 years ago and then you have a seizure, that's not a provoked seizure. Right? A provoked seizure is something that occurs really close in time to when the actual seizure occurs. Stepping away from those sort of definitions and getting into more the meat of the talk, the breakdown of the actual types of seizures, the International League Against Epilepsy has proposed the current classification system for different seizure types. And most of these are pretty similar to the terms that were used in previous versions, but there have been some changes. So amongst seizures, there's really 3 big groups now. There are the focal seizures, the generalized seizures, and then what we've grouped, for lack of a better term right now, into what's called unknown. And I'll explain more about those in the rest of this talk and try and explain why these 3 terms were chosen as the big groups. So when we talk about focal seizures, there are really 3 main types of focal seizures. There's what's called a focal seizure without alteration of awareness. People also use the term a focal aware seizure or a focal seizure without dyscognitive features. Dyscognitive is, I think, kind of a bulky and not ideal word to just say confusion or changes in how your brain is thinking. I prefer using the term focal aware seizure or focal seizure without alteration of awareness. The second type is a focal seizure with alteration of awareness, also called a focal unaware seizure or a focal seizure with dyscognitive features. So the difference between these 2 seizure types is whether or not there's some sort of change in the patient's level of alertness. Now, oftentimes when people hear this terminology, they think about it in terms of conscious and unconscious, meaning essentially totally blacking out and being completely unaware. And while certainly completely losing consciousness is an alteration of awareness, it doesn't have to be that profound, that dramatic to qualify. A focal seizure that just involves some confusion or kind of a fogginess without being totally unaware is still an alteration of awareness. When I'm talking with patients and trying to understand their seizures and try and figure out which category that they fit in, either with or without alteration of awareness, one of the ways that I try and get at that is asking the question, when you have a seizure, if you were standing in the road and a bus were coming at you, during the seizure, could you get away? Right? So would you be able to recognize that's an object coming at me, that's dangerous, I need to move, I need to get out of the way? Are you able to kind of recognize the world around you, figure out what to do, and do it? And if the answer to that question is no, then there's probably at least some degree of alteration of awareness. The final group of focal seizures are what we call focal seizures evolving to a tonic-clonic convulsion. So this is the seizure that evolves to be that shaking of the arms and legs, what people often refer to as a grand mal seizure. That's an older term that we've tried to move away from. So these are seizures that start out as a focal seizure, but eventually spread to involve the whole brain. When we talk about focal seizures, many of you may have heard the term partial seizure in the past. This is the older terminology. Some of you may have also heard the term localization-related seizures. This is another older term. All three of these terms are referring to the same process in the brain. They're referring to focal seizures. With the older terminology, the partial seizure terminology, some of you may have heard terms like simple partial and complex partial seizures. A simple partial seizure is the same as a focal aware seizure, a focal seizure with no alteration of awareness. A complex partial seizure refers to what we now call a focal unaware seizure, or a focal seizure with alteration of awareness. And the final term here, a complex partial seizure with secondary generalization, is the older terminology for what we now call a focal seizure evolving to a tonic-clonic convulsion. When we talk about focal seizures, the reason why we use that terminology is because what happens with the seizure is that it starts in a focal area, an area of the brain. Now, it's easy to kind of misconstrue that statement to believe that it means it starts in a small area. It doesn't have to be a small area. A seizure can start in a whole hemisphere, a whole half of the brain, and that still is a focal seizure. It starts in a part of the brain, as opposed to starting in the whole brain all at once, what we refer to as a generalized seizure, which we'll talk about next. With focal seizures, the behavior, what happens during the seizure, can be very, very different. And there are some terms that we use to describe that. So for those of you who are in health systems where you have access to your medical records and can read the notes, you may see some of these terms. So this will hopefully help you understand what those terms mean and why they're there. We often refer to the seizure semiology. Semiology is just a fancy word for saying the observed behaviors and actions that occur during the seizure. And to figure out what those are, we not only talk to our patients, we also talk to family members and other observers. And of course, if you're in an epilepsy monitoring unit where we have you on video while doing EEG, we can actually see with our own eyes on the video what happens. Many of you may have heard the term aura. That's that first sensation, the very first thing that happens with a seizure. To be clear, auras are part of the seizure. So it's the very, very beginning of the seizure, the very first thing that you experience. Oftentimes, those can be smells or a feeling, like a feeling in your stomach or a feeling that's kind of rising up in your belly. Some people have what are often characterized as psychic experiences. I personally don't really love that term because it sounds very mystical, but really that's that deja vu sort of sensation, for example, or feelings of familiarity or unfamiliarity in settings where you wouldn't expect that. Those are what people are really referring to with psychic experiences. All of those are pretty common auras. It is not always the case that everyone with seizures will have an aura. It is also not uncommon for people to have an aura, but they don't remember it. So the only way that we really know about the aura is if there's somebody there that can talk to them, because as their seizure spreads, as it travels through the brain, they may lose some of their memory, and so they forget what that first feeling was, so they're not able to tell us about it. We've already talked a little bit about alteration of awareness. And really that important thing to remember is that it's a broad range of things. It can range from that mild confusion and fogginess all the way to a complete loss of awareness or loss of consciousness. We often will use a term like behavioral arrest. And that is, as the term kind of implies, it's stopping all your activities. Oftentimes, what people will say is, they start staring or zoning out, or they'll be doing something and then just, it's like somebody pushes the pause button. That's what we will classically refer to as a behavioral arrest. Another term that you'll commonly hear, particularly with focal seizures, are automatisms. These are automatic, kind of unconscious behaviors. And when you see them, they often appear purposeful or semi-purposeful. Lip smacking, picking, so you'll sometimes see people pick repeatedly at like a button, or moving covers, rearranging things on the bed, repetitive movements, that when you see that movement just once or twice, your initial thought is, well, that's a movement that people do, that makes sense. But then you realize it's happening over and over, and there's not necessarily any purpose behind it. That's an automatism. Another term that you will commonly hear used to describe some focal seizures are hypermotor activities. These are faster, larger movements. They generally don't have a purposeful sort of appearance like the automatisms we just talked about. They can be rocking. Oftentimes, people will describe it as a thrashing or shaking, a lot of kind of vigorous movement. Those are hypermotor activities. So that's an overview of focal seizures. So again, just to kind of summarize that, those focal seizures are seizures that start in an area of the brain, and they can spread throughout the brain, but they start out in one spot. That's in contrast to the generalized seizures, which is what we're going to talk about now. And in the generalized seizures, there are 6 different types of generalized seizures. What they all have in common is that they all are believed to start in the whole brain all at once. Now, to be fair, you can start fights in bars amongst epileptologists, which is something to behold, I assure you, over whether a generalized seizure really truly starts in the whole brain all at once, or whether it just starts in a way that looks like it's the whole brain all at once. Whilst that's a really interesting argument for us to have, right now, the evidence suggests that it starts in the whole brain all at once. And for purposes of understanding seizures and understanding treatments, I think that's an appropriate way for us to look at it at this point in time. Those different seizure types are these 6 here. The absent seizure. The absent seizure is one that I think many people are familiar with. Even people who don't have epilepsy or have family or friends with epilepsy have heard about absent seizures. Absent seizures are a behavioral arrest. For those of you who may have seen an absent seizure before, it's kind of like somebody just turns a switch on and off, usually for a relatively brief part of time. So it's usually not 20 minutes, it's usually 20 seconds, 30 seconds. They can sometimes come in groups. So there can be a pause, and then you come back to normal, and then a pause. So sometimes they'll cluster. Tonic seizures. Tonic means that it's stiff. So tonic seizures are stiffening of the muscles. And tonic seizures are generally stiffening of the whole body, although you can have tonic posturing of one side or the other. But a tonic seizure, a generalized tonic seizure, will cause stiffening of the whole body. Clonic seizures are a jerking movement. A tonic-clonic convulsion over here is a combination of both of those movements. So it starts out with the stiff posture of all the arms and legs, and then it evolves to the clonic jerking. So it starts out tonic and then evolves to clonic. An atonic seizure is without tone, meaning that all the muscles basically give out. Classically, this is what people often refer to as a drop seizure. Although, to be fair, tonic seizures can sometimes appear like a drop seizure as well, depending upon the exact circumstances. But with an atonic seizure, all the muscles just give out. If a patient has one of these while they're standing, they will fall down. They don't have muscle tone, so unfortunately, they can't really do the things we would normally do as we're falling, right? We try and shield our head. They're not able to do that. So atonic seizures can be very dangerous for people when they're up and about. And then the sixth seizure type is the myoclonic seizure. This is a muscle jerk. So it's not the repetitive jerking of clonic. It's just a brief, rapid sort of jerk, what we call a myoclonic jerk or a myoclonic seizure. And together, these 6 seizure types make up the generalized seizures. I'm going to go through a couple of terms that are often a source of confusion, one of which I already talked about, the term drop seizure. So classically, a drop seizure is used to refer to anything that causes patients to fall. Classically, typically, this is referring to an atonic seizure. But as I mentioned, a tonic seizure can sometimes masquerade as a drop seizure. Some focal seizures can lead to falls, and so some people will refer to them as a drop as well, although that's much less common. Many of you have probably heard the term grand mal before. This historically referred to a tonic-clonic convulsion. So the seizure that becomes this and then the clonic part of the tonic-clonic convulsion. This term is not specific as to whether it's focal or generalized. And so it is a broader term that doesn't have as much information in it as referring to a seizure as a focal seizure that evolves to a tonic-clonic convulsion, or referring to a generalized tonic-clonic seizure. Another older term that you still will hear are petit mal. Classically, the term petit mal was used for basically any sort of behavioral arrest or staring or zoning out sort of seizure. And this was often thought to be absence. But the reality is that this is a very non-specific term, because if you didn't fit into a big seizure with shaking, you ended up in this category as petit mal. And so focal seizures, absence seizures, any seizure that really didn't evolve to a convulsion often ended up in this terminology. We try and avoid these terms because they don't carry as much information to help us in understanding seizure types and guiding treatment. So these are older terms, but I think it's important that we recognize that they still are out there. Sometimes you'll hear people refer to them. So I like everybody to know kind of what usually is meant by them. Then if we look back at this classification, we've talked about focal and we've talked about generalized. So now we've got unknown. So what is unknown? Well, the unknown comes from not that we don't know that these things exist, but rather focal seizures start in a focus and area of the brain. Generalized seizures start in the whole brain all at once. The things in the unknown category, the infantile spasms, sorry for the typo there, and epileptic spasms, both are less clear which of those two groups they go into. Historically, we tended to think of infantile spasms as something that's more like a generalized whole brain sort of phenomenon. For those who aren't familiar, infantile spasms occur in children in the first year of life. By definition, that's what infantile or being an infant means. And they classically involve kind of a stiffening of the arms. Usually the arms will raise up and the head will drop down. These can occur in clusters that can go on for quite a long time. The seizures themselves, each individual spasm is usually relatively brief, but they can go back to back in very close clusters. Epileptic spasms are essentially the same thing, but occurring in someone who is no longer an infant. And because they have an EEG pattern that typically involves the whole brain and they involve typically both sides of the body, early on we really thought of them as probably a whole brain phenomenon. But what we've learned over time, both looking at EEGs, looking at intracranial EEG data, so using electrodes implanted on the brain, and seeing the results of surgical treatments in some circumstances, there's increasing evidence to say that some of these are more of a focal phenomenon. They seem to be driven by a particular area of the brain, even though they produce an EEG that often looks like it's a whole brain phenomenon. So it seems to kind of masquerade between the two, or flip-flop back and forth as to what the evidence suggests it is. So the classification system felt that the infantile and epileptic spasms really deserve their own category to recognize that there's less that we know, there's more that we need to learn. And so they are in the unknown category. So usually when I get to this point and talking with just about anybody, whether they're medical students, residents, patients, family members, even my epilepsy fellows, they start to wonder, why? Why do we need to make all these terms? Why don't we just call them all seizures? Why did we abandon grand mal and petite mal, right? You just pick one or two words, you call it a day, and let's move on. Well, the reason why we do this is not just because it's fun to make it difficult for medical students and residents to learn and be tested on. The reason is that it matters in a couple of different, very important ways. One, the seizure type, whether they're generalized or focal seizures, can determine some of the treatment options. So some epilepsies respond better to some medication treatments. Generalized seizures, for example, can be made worse by some anti-seizure medications, for example, carbamazepine. So we know that for a generalized epilepsy, like juvenile myoclonic epilepsy, that carbamazepine can make that worse instead of better, even though carbamazepine is a seizure medication. We also know that for patients with focal seizures who have a focal epilepsy, that they may be candidates for epilepsy surgery. If you can identify the focus where the seizures start from, it may be possible to remove that focus. With generalized epilepsy, if the focus is the whole brain, it is not possible to remove the whole brain. And I guess theoretically it is, but that doesn't go well. So knowing whether they're focal seizures versus generalized helps to determine whether or not a resection, removal of an area of the brain, is an appropriate potential treatment. Device therapies like vagal nerve stimulator, deep brain stimulator, and the responsive neurostimulator are currently only approved for focal epilepsies as well. There is some data growing to support the use of some of these devices in generalized epilepsy, but they're not approved yet. So it's not something that, is going to be typically recommended. And then, of course, if we understand the seizure types, that can help us understand the underlying epilepsy, and in some cases may help point us toward a cause or an etiology. It's important to throw the caveat out there that in many cases, understanding the why does this individual have epilepsy, is just not something we can do. Oftentimes, it's just not something that we can figure out with the technologies that we have. But the better we characterize and classify seizures, the more likely it is that we can actually get toward those answers. And with that, I will open the floor up to questions. I wanted to keep this relatively brief so that there were plenty of time for questions, but still made sure that we could get through those three big classifications for seizure types: the focal seizures, the generalized seizures, and then what's grouped in the unknown, the infantile and epileptic spasms. So thank you again, and I'll open up the floor.
Thank you very much, Dr. Carlson. That was terrific. Very appreciative. We've got a couple questions here. First of all, is unaware the same as unconscious?
So unconscious means you are unaware, but you can be unaware while you're still conscious. So an example of that is many patients with focal seizures won't totally black out. So they're still standing up, but they may just say the same thing over again, or they may repeat a phrase that doesn't make any sense, or repeat the last thing that they heard. So they're talking with a friend who said, "Oh, and we need to go get the groceries." And they keep saying, "Get the groceries, get the groceries." And they repeat that. So they're unaware, or at least altered in their level of awareness, but they're not fully unconscious, meaning that they blacked out or are asleep and completely unaware and not interacting with their surroundings.
Okay. Another one here. Does focal mean you know exactly where the seizure is coming from in the brain?
So I wish that it always meant that. So focal means that it starts in an area or a focus. Now, there are some exceptions, right? It's possible to have multifocal epilepsy. So some patients will have a focus and a focus and a focus. So they have more than one seizure type. What focal means is that there is a spot that the seizures are coming from. Whether or not we know where it is, whether or not we can find it, is variable. So if we need to do that, that's where we use things like video EEG, where you would come into the hospital. We would often have to reduce medicines to provoke seizures. So we can look at the EEG and the semiology and the behaviors of the seizure to get clues as to where they're coming from, looking at MRI, looking at magnetoencephalography, looking at the memory testing, the neuropsychological testing, looking at other tests like the PET, looking at language function, which we do usually through functional MRI. All of those things can help us narrow down where in the brain those seizures might be coming from. But unfortunately, sometimes, even with all of that, it can be very difficult to identify exactly where that spot is.
Okay, and here's another one. Is the term seizure disorder different than epilepsy?
It is not. So historically, this term has, the term epilepsy has been around for quite a while. And if we go, I mean, we don't have to go that far back in time. Unfortunately, there was a lot of stigma, a lot of misunderstanding about what epilepsy meant. And so one of the things that kind of gained a little traction was to move away from the term epilepsy and instead use the term seizure disorder, thinking that that would somehow change society's mindset on epilepsy and seizures. My personal opinion on that, which may not be shared by others, but my personal opinion is that was not a great way to approach that. Recognizing the stigma in the United States and across the world that's associated with seizures and epilepsy is incredibly important. And the way to improve that is not to try and change terms to trick people into thinking it's something else. It's instead to do the work, do the lift, and help people understand that seizures don't make somebody, contagious. They don't make somebody evil. They don't make somebody necessarily have limitations with cognition or other forms of disability. While certainly some people with epilepsy have other disabilities, many people with epilepsy do not. And so every individual has their own story. And I personally believe that we should invest our energy in tackling the misconceptions instead of trying to hide it with other terminology.
Okay. About how many seizures would you say there are in total?
So as far as different types of seizures, right, there's those three big classifications: focal, generalized, and unknown. Within unknown, there are two subtypes: the infantile spasms and the epileptic spasms. Within the generalized seizures, there are the six main types. So the tonic, clonic, atonic, myoclonic, tonic-clonic, and absence. Now, if you want to get fancy, and I think of myself if not fancy, there are some subtypes within all of those, some very specific little variations to make that even more complex. Most of those are much less commonly seen, but they do exist. And of course, within focal seizures, there are the three main types: the focal aware, the focal unaware, and focal seizures evolving to tonic-clonic convulsions. So that's where the numbers question is easy. The hard part is that if you ask me how many different seizures there are, I'd probably refer you to something like the number of people that currently live and have lived in the world, because everyone's seizures are their own unique experience. And while there are some very common threads, many people with temporal lobe epilepsy, so focal seizures that start in the temporal lobe, will have many things in common: what they experience, what people observe, the semiology. But each of those seizures will look slightly different: how long they are, exactly what the sequence of events is. So each individual patient has his or her own unique individual seizure. And our role as epilepsy specialists is to try and listen to all that information from patients, from their family members, other bystanders who have witnessed seizures, and put that together with all the data to try and understand where does their unique seizure amongst the millions and even billions of different variations, where does it fit in that big category of 3, focal, generalized, or unknown? And then within, that, if they're focal, which of those 3 is it? Is it focal aware? Is it focal unaware? Is it focal evolving to a tonic-clonic convulsion?
Okay. And another one here. Can you get auras back when you had them, but then don't have them and then have them again?
So some patients will have that. I've worked with patients who had auras early on, and then the auras seem to go away, and then they seem to come back over time. Why does that occur? I think there are a couple of reasons that potentially can lead to that. One is that seizures may just be changing, right? So, the brain is not static, meaning that the brain changes over time. As we age, as life happens to us, there are changes, both good and bad, that happen to our brain and our bodies as we age. So some of it may be driven just by changes. It also can be related to medication. So sometimes starting a seizure medication may change whether or not someone notices or experiences their aura. It may make it so you experience your aura more effectively because you don't lose the memory of the aura when you're on medicine, as one possibility. Or the medicine may block the aura so that you don't notice the aura, but sometimes a seizure can start, but the aura doesn't really rise to the level where you can detect it because of the medication. So changes in medication, as well as changes to the physiology, to the actual workings of the brain, all could potentially cause that to happen.
Okay, another one here. I have both the DBS and the VNS, and I take medicine. Is it possible to have too many meds and devices?
So, that's a tricky question, right? So the short answer I would give to that is no. So here's why I would say no. There's not some magical number that, if you're on 3 medications, or if you have more than one device, that your hair's going to burst into flames or some bad thing always happens. So there's not like a line that is true for every single person. Now, to answer that question in, I think, a more specific way, the answer is it's possible to have too much if it's causing problems, right? When the treatment is worse than what the experience of the seizures are, that's a problem, right? So for some patients, they can be on 2 medicines, but if they don't tolerate those 2 medicines, if those 2 medicines make them so sleepy or so dizzy that they can't function, that's too much medicine for that individual, at least in that combination. Whereas if you're on 6 medications and you're now seizure free and you feel great, even though 6 is a lot of medicines, if you're feeling great on it, it's not too much for you. You're tolerating it. Our goal is no seizures, no side effects. Now, that's not always an easy goal to achieve, but it is always the goal we're striving for. Notice that there isn't a third part that says no more than X number of medicines. If we need 6 medicines, as long as you feel good, as long as it's not negatively impacting your quality of life, it's not too much. And the same is true for devices. We have patients in our group here as well that have more than one of the implantable devices. So that is something that we know can work for some individuals. And it really is very much each individual patient. What is the right strategy to control seizures? How do we use all the tools that we possibly have to make a difference?
Okay. I'm not seeing any more questions at this point. We'll just wait another minute here. If anybody's got any questions, now would be the time to put them in. While we're just waiting another minute, let me also just say that most of our virtual meetups are in our library, our video library. Alicia, can you just type in our website and email address just once more? If you're wondering
Perfect.
about that.
Yep.
Okay, just look in the chat section and take a look at our name of our website and our general email site. And we have most of them. There's some we're not allowed to record, but most of them we are allowed to record. And you can pass this video on to anybody. They are free and anybody's welcome to look at them. But they are in our video library and the website that Alicia is typing in there right now. And you can watch them as many times as you want. So, I am not seeing any more questions. So Dr. Carlson, let me just say thank you very much for your time. You're a busy person. We really appreciate it.
Excellent. Well, it's my pleasure. Hopefully this was helpful and educational for everybody. I wish everyone well, stay safe and healthy. I'm happy to help out any way I can in the future.
All right.
Thank you very much.
Take care. That'll be the end of our program. Thank you, everybody. Seriously, very nice job. That was terrific.
Great, I'm glad. Have a good night.
You too.